Greetings to all. Neck of femur fractures are debilitating and potentially fatal injury for older people. The gold standard of treatment is surgery as it allows for early mobilization and accelerated rehabilitation. Despite this, many still experience a decrease in functional level and poorer health status after. The objectives of this study were to determine the short-term mobility and hip function of geriatric patients who underwent hip replacement surgery for displaced neck of femur fractures in our locality. And secondly, to identify factors which affect the functional outcome of these patients. This was a retrospective review of available medical records. We included those who were 60 years and above and who presented with displaced neck of femur fractures and treated with arthroplasty. We excluded those who had pathological fractures other than osteoporosis. These were the data that we collected, and we performed statistical analysis using SPSS. 168 patients were finally included in the study, of which 70% were female and 30% were male. The mean age of this study population was 75.2 plus minus 8.4 years, ranging from 60 to 94 years old. The large majority of our patients were more than 70 years old at 73.3%. The 70 to 79 years age group constituted the majority of our patients at 38.7%. 58.9% of our patients had an ASA status of 2. With regards to surgical procedure, 56% of our patients underwent a hemiarthroplasty while 44% underwent a total hip arthroplasty. At our institution, all patients had a lateral approach and had a cemented femoral stem. In those who underwent a total hip arthroplasty, a cemented acetabular cup was used. Prior to fracture, 100% of our patients were independent. 79.11% of these patients did not use a walking aid. At 1 year after surgery, 59.6% of our patients remained independent, 28.6% retained the ability to walk without a walking aid. However, only 32.1% regained prefracture mobility status. The mortality rate at 1 year was 14.3%. In our analysis, we found that variables associated with recovery of prefracture mobility were age, ASA status, surgical procedure, and non-hip complications. The hip function at 1 year was assessed using WOMAC scores, and we found that being older and requiring increasing levels of walking aid post-operatively resulted in worse WOMAC physical function scores. There were no differences or correlations found between WOMAC scores and other variables. When analyzing the subgroup of surgical procedure, we found that patients who had a total hip replacement were significantly younger. More of them were subjected to general anesthesia, they had a longer duration of surgery, and they had more blood loss. However, there was no difference in hip function and hip-related complications. The demography of our study population was reflective of local and regional trends. However, our patients were relatively younger than those reported in other regions. The main finding of this study was that only 32.1% of our patients regained prefracture mobility. Some of the possible reasons include increasing frailty or the lack of effective rehabilitative measures and monitoring of care delivery after discharge. Therefore, early geriatric intervention and improving access to rehabilitation services may prove beneficial. The mortality rate was interestingly lower than reported in other studies. This could be attributed to a small sample size or improved quality of care within our healthcare system. From this study, patients who had a total hip were more likely to remain independent, more likely to regain prefracture mobility, and to continue ambulating without an aid. However, there was a selection bias here, as at our institution, if the patients had pre-existing hip pain or if the Cernbu score was more than 60, these patients were planned for total hip. The mean age of our study cohort was 75.2 years, and the average lifespan of our population was 75.6 years. With this in mind, and that there were no observed differences in hip function or complications after surgery in the short term with regards to whether a total hip or hemiarthroplasty was used, so it may be reasonable to choose a hemiarthroplasty in this age group, even though patients meet the criteria for total hip arthroplasty, especially if cost is a factor. The limitations of this study was that it was a retrospective review with a relatively small sample size and short follow-up. Also, there was a lack of information regarding the rehabilitation process. In conclusion, the majority of our patients did not regain their prefracture mobility despite surgical treatment, and there were no observed differences in hip function between those who had a total hip replacement and those who had a hemiarthroplasty. Thank you.